All right, let's talk about one of the most terrifying, time-sensitive crises in all of neurology, status epilepticus. This isn't just a seizure. It's a full-blown neurological emergency where the brain is literally stuck in an ongoing state of seizure, and every single second that ticks by puts brain cells at risk. So, let's get right into it.
So, let's put you right in the room. You have a patient, they're convulsing, and you look up at the clock. It's been more than 5 minutes. You know, right then and there, that their brain is in overdrive, and its natural safety switches have failed. This is status epilepticus. What you do in the next few minutes? Well, that can mean the difference between a full recovery and permanent brain damage.
So, to get a handle on this, we're going to break it all down. We'll start with the basics. What even is status epilepticus? Then we'll get into the why, what's going on in the brain. From there, it's all about recognizing the signs, how to diagnose it, and the super important treatment steps. And finally, we'll touch on the aftermath.
All right, first things first, what are we actually talking about when we say status epilepticus? Because, it's not just about how long a seizure lasts. It's way deeper than that. It's about a complete breakdown of the brain's own safety net. So the official definition from the International League Against Epilepsy, or ILAE for short, gets right to the heart of it. Think of it like this. It's not just that a seizure is lasting a long time. It's that the brain's off switch is completely broken. And when that happens, it kicks off this dangerous domino effect that can literally start killing brain cells. That's the key takeaway here. It's a distinct, dangerous state, not just a long symptom. Okay, so to handle this in a real emergency, the ILA came up with a super smart framework. It's all about two critical time points, T1 and T2. Think of T1 as the fire alarm. It's the point where we go, okay, this has gone on too long. We have to act right now. Then there's T2. T2 is the point of no return. It's when we know that permanent brain damage is starting to happen. It's our absolute deadline. And check this out. These time points aren't one size fits all. They change depending on the type of seizure. For that classic full-body convulsive seizure, the tonic-clonic kind everyone thinks of, T1 is just 5 minutes. That's it. That's our trigger to start treatment. And T2, the danger zone for brain injury, hits at 30 minutes. Now, if you look at other types, like a focal seizure or an absence seizure, the clock is a little more forgiving. But no matter what, the fundamental rule is always the same. Time is brain. Now, this is super important. Status epilepticus doesn't always look like what you see in the movies. We basically split it into two big categories. You've got convulsive SE, which is the obvious one with all the shaking and visible motor stuff. But then there's non-convulsive SE, NCSE. And this one is sneaky. It's a silent seizure. The brain is on fire, electrically speaking, but on the outside, the person might just look confused or out of it or even be in a coma. It's so easy to miss and just as dangerous. Okay, so we've got the what. Now let's get to the why. I mean, why doesn't the seizure just stop? The brain is supposed to have these built-in brakes, right? So why do they fail so spectacularly? Well, to figure that out, we have to zoom in and look at the brain's chemistry. I love this analogy because it makes it so clear. Imagine the brain is a car. The brakes are your inhibitory system run by a chemical called GABA. And the gas pedal? That's your excitatory system run by glutamate. Normally, they're in perfect balance. But in status epilepticus, it's like a nightmare scenario. The brakes completely give out. The GABA receptors literally get sucked away from the surface of the cell, and at the same time, the gas pedal gets jammed to the floor. You're left with a runaway car, a brain that just can't stop firing. So what kind of things can push the brain into this state? Well, the triggers are pretty wide-ranging, but you can kind of group them into two main buckets. You've got your acute causes. These are sudden hits to the brain. Things like a stroke, a bad infection like meningitis, or a head injury. Then you have the chronic causes, which are tied to ongoing issues. And honestly, one of the most common reasons we see this is simply a patient with known epilepsy who, for whatever reason, stops taking their anti-seizure meds. Okay, we've covered the what and the why. So let's talk about the how. How do you spot this in a patient? Because recognizing it, and recognizing it fast, is where the race really begins. With convulsive status epilepticus, the signs are usually pretty hard to miss. You've got the sustained jerking or siphoning, and the person is clearly not conscious. But what's happening on the inside is just as dramatic. The body gets flooded with adrenaline and other fight or flight hormones. This makes the heart pound, the temperature shoot up. It puts a massive strain on the whole system. And the muscle contractions themselves can be so violent they can actually break bones or dislocate joints. But what about that silent seizure we talked about? Spotting nonconvulsive SC is a whole different ballgame. It's so much trickier. The symptoms can be negative, or someone loses a function, like they suddenly can't speak or they're just deeply confused. Or the symptoms can be positive, where they start doing something abnormal, like repetitive lip smacking, or their eyes start twitching back and forth. The bottom line is, any patient at risk who has a sudden, unexplained change in their mental state, you have to be thinking, could this be NCSE? And that leads us to probably the single most important rule in managing status epilepticus. In this emergency, you do not wait. You treat first and ask questions later. You simply have to act. Yeah, this quote really nails it. Do not delay therapy to obtain an electroencephalogram, EEG, in clinically apparent status epilepticus. It's as simple as that. If someone is obviously seizing in front of you, you don't say, let's wait for the EEG tech. No, you treat them right then and there. All the diagnostic stuff, that happens at the same time as the life-saving treatment. Waiting is just not an option. So you've got this incredible parallel process going on. One part of the team is pushing meds to stop the seizure, while another part is running through a diagnostic checklist. First up always is a fingerstick glucose right at the bedside, because low blood sugar can cause this, and it's an easy fix. At the same time, labs are being drawn. A CT or MRI is being ordered to look for things like a stroke or a tumor, and if there's any hint of infection, a lumbar puncture is prepped. And yeah, you're getting that EEG ready to go. And here's what that electrical storm in the brain actually looks like. That's an EEG, and putting a patient on a continuous EEG is so critical. I mean, for non-convulsive status, it's really the only way to know for sure what's going on. But here's the kicker. Even in someone who was having a convulsive seizure, they might stop shaking on the outside, but their brain could still be seizing on the inside. The EEG is the only thing that tells us if the brain is truly quiet and if our treatments have actually worked. All right, let's get into the main event. The action plan, the treatment protocol. This is a clear, step-by-step game plan that is completely dictated by the clock. And the goal is simple: stop the seizure fast. So the second you suspect it, the clock is on. And in those first 5 minutes, it's not even about the seizure-specific drugs yet. It's all about the basics: airway, breathing, circulation, the ABCs. You make sure they can breathe, you slap on some oxygen, you get an IV in, and you check that glucose. You have to stabilize the patient first. This is the foundation for everything that's about to happen. Okay, we just blew past the 5-minute mark. We've crossed T1. Now it's go time for the first-line meds. And the undisputed champs for stopping a seizure in its tracks are the benzodiazepines. Remember those broken brakes in the brain? Benzos are like a super-powered emergency brake. They come in and crank up the power of GABA, the brain's main calm-down signal, to try and shut the seizure down. So which benzo do you grab? Well, if you've got an IV line in, lorazepam is usually the go-to. But what if you're a paramedic and you can't get an IV started? This is where midazolam is an absolute lifesaver. You can just give it as a shot in the muscle, an IM injection, and it works like a charm. Diazepam is another good choice too. The key is to get one of them in and get it in fast. But what happens if the benzos don't cut it? If the seizure is still going after 20 minutes, we have to move on to the second line of defense. And there's a really important reason for this. The longer the seizure goes on, the less well those benzos work, because the GABA receptors start to disappear. So we have to switch gears and bring in the bigger guns, longer-acting IV drugs that work differently, like phosphoniditone, valproic acid, or levetiracetam. We're trying to build a more lasting wall against the seizure. And if even that doesn't work, well, now we are in deep, deep trouble. This is called refractory status epilepticus. At this point, the patient is headed straight to the ICU. The next move is basically to shut the brain down completely. We induce a medical coma with a continuous IV drip of a powerful anesthetic, something like propofol. The goal is to force the brain into electrical silence, which we confirm with the EEG. And of course, this means the patient has to be on a breathing machine. So let's say we finally get the seizure to stop. The battle is won, right? Not exactly. The fight is far from over. A prolonged seizure is like a hurricane tearing through the body, and now we have to deal with all the damage left behind. And the list of things that can go wrong is, well, it's pretty scary. The brain can swell up, heart rhythms can go haywire, people can aspirate and get a nasty pneumonia. The muscles can break down so severely, a condition called rhabdomyolysis, that they flood the bloodstream with toxins and cause the kidneys to fail. It's not a brain problem at this point, it's a whole body crisis. And this just drives home how high the stakes are.
For the absolute worst cases, the ones we call super refractory, where the season continues even in a medical coma, the mortality rate is just staggering, 30 to 50%. Think about that. Up to half of these patients will not make it. That number just hammers home why every single second, every single step in that protocol is so unbelievably critical.
So, you see, status epilepticus is the ultimate race against time. It takes a team that's drilled, that's coordinated, and that can execute a complex plan flawlessly under immense pressure. From spotting the signs to hitting every treatment window on time, it's all about speed and precision. And it leaves us with one final critical question. When this emergency comes through your doors, is your team ready?